We are live. Shravani, we are live. Please go on.
Okay, sir. Shall I start, sir?
Next. Yeah, please start.
Okay. So, good morning, everyone. Today, my topic is on ultrasound in ICU and the expanding indications for the ultrasound in the ICU. So, this point of care ultrasonography is widely used by intensivists for the rapid and accurate diagnosis of many life-threatening conditions like pneumothorax and cardiac tamponade, etc., and also for monitoring of the patient in various systems and procedural aid, and it is becoming more established and refined. The device and technological advancements that will lead to rapid assessment of the images lead to handheld devices, and complementing to this, the software and artificial intelligence-based solutions have been developed, which will provide the real-time image analysis and feedback to the user both in traditional and handheld devices. The critical care ultrasound is not only a diagnostic tool for providing information regarding the source of the critical illness, and it also becomes the component of the patient physical examination in a day-to-day basis. From the head to toe, we can do an ultrasound, including from the brain, heart, lung, abdomen, vasculature, and including the muscles. Coming to this software-based solution for the ultrasonography in upcoming critical care, it will provide you for the anatomical identification, like what chamber we are looking at, or whether it is the B lines in case of lung ultrasound, and a quantitative analysis like a calculation of ejection fractions or quantification of the pleural fluid, etc. And the preset multi-system protocols will aid in the memory of the scanning in specific areas, like in trauma for the fast, and shock for any rush protocol and the false protocol. This is the next upcoming of the ultrasound in critical care with the use of artificial intelligence. In this, the initial assessment of the patient by a physician in the remote area by using the ultrasound, and the artificial intelligence-based software analysis will provide the good image and provide the additional information regarding the image, and it also gives some measurements. In addition to this, the remote telemonitoring from an expert colleague in other institution will make sure that high-ensure image acquisition and interpretation and clinical discussion with the physician in the remote area. This in turn lead to correct diagnosis and management of patient, which otherwise will be missed in case by physical examination. This all together lead to the better outcome of the patient. This will be the future of the artificial intelligence-based ultrasound. Coming to the ultrasound neurocritical care, we commonly use conventional transcranial Doppler and a B-mode transcranial color-coded duplex ultrasonography. We use low-frequency probes for the better penetration, and use 4 transcranial windows like transtemporal, submandibular, hospital, and ocular. And a phased arrays we use to visualize the intracranial blood vessels, and the linear probes are used for optic nerve sheath diameter for estimation of the in case of raised ICP. The two modalities of transcranial Doppler are, one is the conventional, the probe which we are using, it is a Doppler probe, and another is the transcranial color-coded duplex sonography, which one used with the phased array probes. This is the image of the transcranial Doppler, which is the Doppler probe. This is the TCCCD. Along with that, we use here the pulse wave Doppler to measure the cerebral blood flow velocity. Along with that, we can see the intracranial structures. Coming to the role of TCD, in case of the ischemic stroke, it will aid in diagnosis and management. Suppose in case of occlusive lesion, the sensitivity, specificity, and the positive predictive value and negative predictive value exceed the 90% in case of middle cerebral artery lesions. However, it goes to 70 to 90% in case of vertebral artery and basilar artery lesions. However, the gold standard techniques being the CT and MRI, and TCD acts as an adjuvant in a CT angiography to detect the early occlusive lesions and differentiate it from the hemorrhagic and ischemic stroke. TCCC used to detect the midline shift in case of the malignant MCA tertiary infarcts, And TCD used to assess the cerebral hemodynamics to calculate the TB score and assess the severity of the score and predict the clinical recovery of the patient. The sonothrombolysis, which is along with the recombinant tissue plasminogen activator in thrombolysis, along with the TCD, results in a better recanalization of the intracranial large vessel occlusions and result in a better patient outcome. The trial is a clot-based trial which showed improvement in recanalization and functional outcome at 3 months in the patients. And TCD is a valuable tool in early diagnosis of cerebral vasospasm in case of unresolved subarachnoid hemorrhage and could guide in implementation of the therapeutic strategies as early as possible. The high sensitivity and specificity of in case of middle cerebral artery vasospasm, but diagnostic accuracy is low in case of basilar artery, anterior cerebral artery, and posterior cerebral artery. And the rates of cerebral mass based on the TCD is the measurement of the mean flow velocities in the middle cerebral artery and in case of posterior circulation, including the basilar artery. The Lindegaard ratio and the CV ratio used for the severity of the vasospasm in case of anterior and the posterior circulation strokes. The TCD in cerebral autoregulation, it is the cerebral autoregulation get affected in traumatic brain injury, subarachnoid hemorrhage, ischemic cerebrovascular accident, and carotid arteriosclerosis. The TCD is validated tool in measuring the both static and dynamic autoregulation. TCD can also be used to measure the cerebral autoregulation and vasoreactivity in case of TBI. The indices used in TCD and TCCD in cerebral autoregulation are autoregulatory index. It measures up to 0 to 9, and anything more than 4 is considered as abnormal. And transient hyperemic response, which is done by ipsilateral carotid artery pressure, and the TCD based calculation of the mean flow index. The role of TCD in case of brain death, TCD can also be used to demonstrate the arrest of cerebral circulation following the brainstem death. American Society of Neurology recommend the utilization of TCD in confirmation of brain death. The sensitivity comes around to 89 to 100% and specificity is around 97 to 100% in confirmation of brain death. This is the TCD showing the normal MCA vessel flows in a normal healthy patient, and in case of the raised ACP where the diastolic component is getting decreased, where the ICP is equalizes to the diastolic pressures, and this is in the case of cerebral circulatory access where there is the oscillating flow is seen. Coming to the role of optic nerve sheath diameter, the measurement of optic nerve sheath diameter at the bedside can detect the raised ICP as well as even before the clinical symptoms arise. The linear probe is placed over the eyelid and optic nerve sheath diameter is measured at the 3 centimeters from the posterior part of the globe. The advantage of using the optic nerve sheath diameter as an indicator of raised ICP is it is non-invasive, diagnostic, accuracy, and reproducibility, and it will also guide in monitoring the response to therapy. The pupillary examination with ocular ultrasonography in case of patients with head trauma where there is a soft tissue edema and a swelling where the eyelids are completely closed, where we can't do the normal pupillary examination with the light, where we can utilize the use of ocular ultrasonography. Coming to the ultrasonography in case of lung, the lung ultrasonography gained the leading position in critical care. Both are diagnostic and a monitoring tool. The accurate bedside with a clear diagnostic criteria for most of the causes of the respiratory failure have been explained with the help of the blue protocol, and distinguishing the hypovolemic from the other causes of the shock and limiting the fluid administration is obtained with the false protocol. And apart from that, it also helps in guiding the ventilatory setting, fluid administration, antimicrobial therapy, and diaphragmatic assessment. And also helps in the procedural guidance in the case of thoracosynthesis, percutaneous dilatation, and tracheostomy. In case of emergency, like a focused examination can be done, like in case of diagnosis of the pneumothorax, where the anterior fields in case of supine position can be done, or in case then a systemic and complete examination include the 4 regions of the hemithorax bonded by the sternum and anterior and the posterior axillary lines and divided into superior and inferior parts. Each hemithorax includes the six regions. Coming to the role of lung ultrasound in ARDS, it helps in diagnosis and it included in the global definition of ARDS where the use of ultrasonography in the resource limited settings. And this is the one where the ultrasound can be used to identify the bilateral loss of lung aeration with multiple B lines or consolidation as long as the operator is well trained in the use of ultrasound. Apart from that, the use of lung ultrasound in the new definition of acute respiratory distress syndrome, it increases the occurrence rate of ARDS because of the high sensitivity and moderate specificity. However, this can be overcome by the use of lung ultrasound ARDS score, where the lung ultrasound score, along with the pleural and subpleural abnormalities in the anterior lateral regions, has the high accuracy in diagnosing and excluding the ARDS when compared to the bilateral lung ultrasound findings. The basic lung ultrasound findings and the aeration scores include A lines include the 0 or less than 2 B lines, and the score 1 include the B lines occupying less than 50% of the pleura, and if it is more than 50%, the score will be 2, and the consolidation will be given the score of 3. Along with this, any abnormal and subpleural consolidations can be accounted for in the anterior lateral regions of the lung are taken into consideration for the ARDS. Along with that, lung ultrasound can be used for the predicting the ARDS morphology, both in focal and non-focal type of ARDS. This in turn lead to better treatment approach to the subphenotypes. The non-focal phenotype has a diffuse patchy aeration loss, which will better respond to the recruitment maneuver, whereas the focal phenotype, mostly located in the dorso-inferior regions, better responds to the proning positions. Along with that, it also helps in the monitoring of the ARDS patient, like ARDS aeration monitoring daily, done with the use of lung ultrasound scoring, and use of recruitment maneuvers and following with the lung ultrasound provide the how is the aeration in the lung zones, and also guide in the titration of the PEEP. And also helpful in the fluid resuscitation, where the new occurrence of the B lines will tell you the fluid overload condition. And the lung ultrasound score assess the severity of ARDS at the admission and to monitor the lung aeration on the daily basis. Useful especially in the patients on ECMO, where the chest X-ray is purely informative and transport to the CT scan is difficult. The progressive decrease in the lung score implies the recovery and observed in patients with a good outcomes. Unexpected increase in the lung ultrasound score leads to the progression of ARDS or any supervening infection like a VAP. Lung ultrasound score variation after a week of antibiotic will correlate with the quantitative CT scan. And use of lung ultrasound in case of weaning of ARDS patient. It has a utility in predicting the success of extubation following the spontaneous breathing trial. The increase in the lung ultrasound score between the beginning and the ending of the spontaneous breathing trial predicts the extubation failure. This is indicating the de-aeration and fluid accumulation within the lungs and leading to the extubation failure. Coming to the assessment of diaphragm by ultrasound, the mechanical ventilation leads to diaphragmatic muscle injury and leading to dysfunction. The inadequate mechanical ventilator support, either over or under assistance in adapting to the patient inspiratory efforts, is the main mechanism behind the diaphragmatic injury. In case of over assistant, it will lead to atrophy, and in case of under assistant, it will lead to the inflammation and the muscle injury. To protect the diaphragm, it requires the tools to monitor what is the diaphragmatic effect and detect any patient ventilatory asynchrony. For this, esophageal monitor and electrical activity of the diaphragm are needed, but these are very expensive or not available all the time. However, the ultrasound is bedside and easily available and non-invasive and can be easily available in all settings. Diaphragmatic dysfunction is underestimated phenomena that may pre-exist at the time of ICU admission or may develop as early as within the 24 hours of ICU admission. Why to do a diaphragmatic ultrasound? For the assessment of diaphragmatic function over the time, whether it is normal or getting reduced, leading to weakness and completely lost in case of paralysis, and assessment of risk of successful or failed mechanical ventilation weaning, and guidance for the management of ventilatory settings, and monitoring the diaphragmatic thickness over the time for prognostic purpose. And what is measured in the diaphragmatic ultrasound? It is the diaphragmatic excursion, and the target value of less than 10 to 15 is considered as weak, and thickening fraction of the diaphragm, which is measured by the end inspiratory thickness minus end expiratory thickness by the end expiratory thickness. The value less than 20% is considered as a failure of weaning, and the velocity of diaphragmatic motion, which is done by thickness and tissue Doppler imaging, and relaxation velocity is calculated. And diaphragmatic mass and end expected thickness is considered diaphragmatic mass, and it is a marker of severity of the underlying illness. And when to do the diaphragmatic ultrasound? As we know, the diaphragmatic weakness may present even at the time of admission to the ICU or the ER, and the measurement of diaphragmatic excursion and thickening fraction. Pre-existing diaphragmatic weakness is seen, and it associated with the failure of non-invasive ventilation, or internally lead to prolonged duration of mechanical ventilation and the poor outcomes. And thickening fraction of the diaphragm less than 20% is associated with NIV failure in a patient with acute exacerbation of COPD, and diaphragmatic excursion of less than 1.2 centimeters lead to increased duration of the mechanical ventilation. Thickening fraction of diaphragm is used to titrate the ventilatory support as a part of diaphragmatic protective ventilation. The thickening fraction between 15 to 20% during the initial days is associated with the stable muscle thickness. So anything less than 15% is associated with the over assistance, and more than 30 to 40% is associated with the under assistance. During the weaning from where the diaphragmatic excursion and thickening fraction provide useful measures for assessing the patient effect. Thickening fraction of the diaphragm strongly correlate with the muscle strength, where the diaphragmatic excursion during the spontaneous breathing trial was found to be reliable measure for unsuccessful breathing trial. This is how we do the diaphragmatic ultrasound, both in the anterior in the subcostal view and in the anterior axillary line. Coming to the ultrasonography of the heart, the critical care echocardiography is at the two levels, and at the basic level, and the performed for the focus performed for the goal-directed examination, and the advanced critical care echocardiography, which utilizes a quantitative assessment of cardiovascular function like calculation of ejection fraction, grading of the diastolic dysfunction, and hemodynamic assessment and monitoring of the fluid status. Assessment of left ventricular systolic function, cardiac output with the use of velocity time integral, RV function, diastolic dysfunction, valvular pathologies, volume status, and fluid responsiveness. And the new one is the venous condition evaluation by ultrasound, that is VEXUS score, evaluate the scores and the severity of the venous condition, not only of IVC, but also of the liver, gut, and the kidney. When to use the VEXUS score is when to assess the fluid status of the patient and who are at the risk of fluid overload in case of septic shock, congestive heart failure, and those with acute kidney injury. It will help to whether to start the IV fluids or will stop the resuscitation, or with the use of diuretics or in vasopressor support. And VEXUS score should not always be used in conjugation with the clinical picture of the patient, lab values, hemodynamic status of the patient. The evidence of venous condition and early signs of end organ damage will optimize the treatment accordingly. Coming to the VEXUS protocol, in the first step, we will do the calculate the IVC diameter, which is done subxiphoid measurement. If the IVC diameter is more than 2 centimeters, then we will go to the second step. In the second step, where we measure the hepatic vein Doppler, it can be done where we can see the probe can be placed in the anterior axillary line, where we can see the middle hepatic vein, right hepatic vein, and the left hepatic vein will be placed in the anterior. And usually we will take either right or middle hepatic vein. When we place the color Doppler, we will see the blue color where the blood is flowing towards the IVC. from the hepatic vein. And we will take the pulse wave Doppler of the hepatic vein, where the hepatic vein entering the IVC. In normal, there will be the systolic and diastolic components of the hepatic vein, and the systole being more than the diastole. In the mildly abnormal, or where it is showing the mild condition, the increase in the diastolic component more than the systolic component. And in case of severely abnormal, where it is indicating the severe condition, where the reversal of the S wave and diastolic being the more than the systole. And next, coming to the portal vein Doppler, and it is done when in the mid-axillary line, placing the ultrasound probe, and usually it has a monophasic flow, and by measuring the pulsatility index, it is measured by the velocity maximum by minus velocity minimum by velocity maximum. Where the pulsatility index is less than 30%, it is indicating the normal, and it is between 30 to 49% indicating the mild condition, and more than 50% indicating the severely abnormal, indicating the severe condition. Then coming to the renal vein Doppler, it is the most difficult part in the VEXUS ultrasound, where it is taken in the posterior axillary line, and usually we get interlobar veins where the continuous monophasic flow is seen. In case of mildly abnormal, there is a discontinuous biphasic flow with both systolic and diastolic phases. In case of severely abnormal or more condition, where the discontinuous monophasic flow with only diastolic component being measured. Interpretation include the grade 0 when it is taken when the IVC diameter is less than 2 centimeters, the grade 1 along with the IVC more than 2 centimeters, and any of the normal or mildly abnormal patterns are seen. In case of grade 2, only one severe abnormality in any one of the components like hepatic vein or portal Doppler and renal vein. In case of grade 3, there will be more than 2 components of severely abnormal values. Coming to the limitations of the VEXUS, well assessment of fluid status, but not relate to the cause of the venous condition. IVC measurement affected by the intra-abdominal pressure independently of the right atrial pressure and also by the chronic pulmonary hypertension. The hepatic vein measurement may not be affected by tricuspid regurgitation if the right atrium is still able to expand and contract. In case of chronic liver disease, hepatic vein pulsatility is still present even with the significant conditions. Coming to the nutritional assessment by ultrasound, in ICU, the bed rest, decrease in nutritional intake and inflammation will lead to loss of muscle mass and ICU acquired weakness. Low muscle mass at the ICU admission is associated with increased mortality, and muscle mass is a part of malnutrition diagnosis and according to CLIN criteria and ESPAN guideline on clinical nutrition. Techniques of measuring the muscle mass include CT, bioimpedance, and ultrasound. Ultrasound being the non-invasive and easily available at the bedside, it will take an option. Ultrasound of the muscle is promising approach to diagnosis of the even neuromuscular disease in critically ill patient, where we can measure the cross-sectional area of the nerves and muscle of the critically ill patient. The two goals of assessment of muscle mass include the current muscle mass assessment, where we can go for the nutritional assessment and risk stratification. According to that, we can intervene with the patient and monitor the progression of the muscle loss or the recovery, and which muscle being used is the rectus femoris muscle area and the rectus femoris with the vastus intermedius thickness, that is the quadriceps muscles layer thickness measurement. Among this, rectus femoris muscle area being encouraged than the quadriceps muscle layer thickening. This is the overall use of lung ultrasound in critical care. In the brain, we can use to measure the intracranial pressure, cerebral perfusion pressure, and intactness of the autorelation can be checked both static and dynamic, and case of diagnosis of intracerebral hemorrhage. In case of lungs, quantification of the pleural effusion, pneumothorax, causes of respiratory failure, along with the use of the, in case of ARDS, monitoring and weaning from the mechanical ventilator. And both in the case of right and left heart dysfunction, pericardial effusion, and a diaphragmatic thickening and excursion, and the weaning in a diaphragmatic protective ventilation and weaning from the ventilator. In case of the free fluid in the abdomen or any diagnosis of aortic artery aneurysm, but in case in the trauma as a fast protocol, and anatomical evaluation of arterial and venous cannulation in case of multiple failed attempt, and as well as diagnosis of the DVT.
Thank you, Shravani. It was a very concise and comprehensive review of the role of ultrasound in clinical practice, expanding indications. While we all know that ultrasound has been used for a long time in identifying liver diseases, ascites, and all other complications, now it has become an extension of the clinical assessment of a patient in the ICU. Just as you know, ABG is a clinical science, sonographic findings are also become part of. Suppose we have a patient on CRRT who has been initiated on ultrafiltration, for example. Such a patient's progress, not only in terms of the total net removal of fluid, can also be understood by the assessment of how much volume we have been able to decongest the patient by using the ultrasonographic parameters. Lung protection, ARDS management has gone beyond simple lung protective ventilatory strategy. We have gone towards diaphragmatic protective ventilatory strategy, and we have gone towards right ventricular protective ventilatory strategy. So the last two, that is diaphragmatic protection and right ventricular protection, are assessed by sonography in a patient who's bad ARDS, whether he's prone or he's on any other ventilatory strategy. One of our students, Shabir, actually presented his data about the reliability of transcranial Doppler in early identification of deterioration among patients with ischemic stroke. It was very insightful information we got from this study, that if you can do a good transcranial Doppler in the first 12 hours after the patient comes to you with acute ischemic stroke, you can actually identify in which patient osmolar therapy is working and in which patient the osmolar therapy is not working in terms of cerebral perfusion. So the roles of ultrasound are expanding, and as intensivists, it is our responsibility to know when to use ultrasound and when a patient will benefit with the use of ultrasound, because our patients can sometimes not be able to leave the ICU for a CT scan or for other imaging modality. So it's a very useful tool, and all of us now have learned the art of ultrasound. It was an excellent presentation. Ghanshyam, you want to add something?
Thank you, Srinivas and Shamli. Just a couple of points. For one, see, no doubt about the fact that ultrasound is becoming a major, a tool in managing critical ill patients. However, please kindly remember that it is something which has to be done in a given clinical context as a complementary to your clinical skills or clinical examination. Of late, at least that's been my observation, that most of the time when you ask something about a patient, a lot of students tend to tell about ultrasound findings and then fail to correlate that clinically. That is one thing. Always keep in mind that it's fantastic when you actually correlate it with your clinical examination. The second thing is the role of ultrasound as a means of assessing and stratifying gastrointestinal failure. There's no doubt about the fact that ultrasound is now invaluable in assessing your cardiovascular function, your respiratory function, your neurological function. But from the perspective of GI function, it is a very simple bedside tool which can help you assess what's happening with your gastrointestinal function. Again, something that we are doing a study on this. One of our DNP students is doing at the role of ultrasound in assessing gastrointestinal function. Hopefully, we'll come up with a publication soon. So, it is indeed an invaluable tool, but please, try to utilize it in context of the clinical situation as a complement to your clinical examination. Thank you.
Thank you, Ghanshyam. We'll meet again next week with another session on Higgs program. As the nation goes to poll, Please do exercise your right to vote and make a difference for this country. Thank you very much and meet you next.
Thank you, sir.